I want to welcome you to Ovarian Cancer Canada's webinar entitled Ovarian Cancer 101, presented by Dr. Alon Altman. I will give a more full introduction of him in just a moment. My name is Marilyn Sapsford, and I'm the Manager of National Programs at Ovarian Cancer Canada, and I will be moderating the session tonight. Dr. Altman will speak for about 30 minutes, and if you have questions that come up during the presentation, please type them in the Q&A box that is just below the two webcam pictures, and you can type your question in that box. We will wait until the end of the presentation to address the questions. And I would ask you to please remember that the speaker can't answer any personal medical questions. So please keep that in mind as you're thinking of questions and how to word them. If you do have any technical issues through the presentation, you can communicate with our technical person by typing in the chat box, as people have been doing to indicate where they're from and so on. So if you have any technical issues, please type in that chat box and our technical person will respond to you. There may be some people who are calling in by telephone only, and if that's the case, you will be able to hear the presentation, but obviously you won't be able to see the presentation, and unfortunately you won't have the opportunity to ask any questions. This presentation is being recorded and will be available on our website in the next week or so. So I'd like to introduce our speaker tonight. Dr. Alon Altman grew up in Port Coquitlam, BC, and finished his Bachelor of Science in Honours Genetics and Doctor of Medicine at the University of British Columbia in 2004. He then went on to complete residency in the Department of Obstetrics and Gynecology at Dalhousie University in 2009, and his fellowship in gynecologic oncology at the University of Calgary in 2011. He currently works as a gynecologic oncologist and associate professor at the University of Manitoba and the Winnipeg Health Sciences Centre, Cancer Care, Manitoba. Dr. Altman is also a very well-respected member of the gynecologic community in Canada. He is chair of the annual general meeting for the Society of Gynecologic Oncology of Canada. He's also the co-chair of the Education Forum for the Communities of Practice, and also the co-chair of the Canadian Obstetrics and Gynecology Review Program. If you can say all of that very quickly, you're doing well. Dr. Altman is married, he says, with 3 amazing human children, as well as 2 amusing canine children. So I think he has a busy and full house. He spends lots of his free time camping, running, and chasing children around. So thank you, Dr. Altman, for being with us tonight, and I will turn the presentation over to you.
Well, thank you. Hopefully everybody can can hear me. It's kind of amusing to hear the description of myself. It's been a long road, I guess. Ovarian Cancer Canada certainly helped me out with the electives grant that the training award that Ovarian Cancer Canada provides. I think it's the Bruce Galloway Award. I was one of the first people that got it, and lo and behold, I became a gyne-oncologist, I'd say in no part due to the support. So I'm certainly happy to help Ovarian Cancer Canada out, and certainly enjoy teaching and have done patient presentations before. So I will try to get through this, but I know you all probably have some questions, and hopefully we'll be able to address them to the best of my ability. So we're going to talk about ovarian cancer. Big thank you to Danielle Vikas and Jean Gregoire. I had looked at Danielle's slides from when she had previously done this and made adjustments, but obviously the topic is pretty much the same, and Jean Gregoire had presented ovarian cancer for the Canadian Obstetrics and Gynecology Review Program, and I have used his slides for that for many, many years, and have used some of his ideas as well for this project. Sorry, that's my phone in the background. All right, so I think I used this one. Yeah. So we're going to start by going through general information. We're going to go through different groupings, histotypes, or pathology of ovarian cancer. We're going to go through the hereditary or familial component, and then go through some of the treatments, go through what we've always done, the new, the good, and potential future goals and targets. So we'll start with general information for ovarian cancer. I pulled off some statistics from the Canadian Cancer Statistics website. This is 2015, but they probably would have 2016 up relatively soon. They're usually pretty good about staying close to the calendar year, but this is just an idea of the burden of ovarian cancer across the country. So obviously this one only affects females, but it is the 7th most common cancer in Canada for women, and affects 2.9% of the population. The number ranges depending on where you look from 1.5% up to 2.9%. If you compare the lifetime probabilities of getting cancer, you can see ovaries right there at 1.5%. Uterus is our most common cancer that we treat, which is a 2.6 lifetime probability, and cervix is much lower. This obviously changes depending on what country you're in, and within the developing world, cervix is much, much more common, and takes over as the most common gynecologic cancer, pushing ovary down to the 3rd. If you look at this slide, I think I have an old slide set, but that's okay. I'll go through this one. If you look at the causes of death, the reason we concentrate on ovarian cancer so much is because even though it's the 7th most common cause of cancer, it bumps up for causes of death. Now, it's still not a common cause of death, but it is certainly up there, and because of that imbalance, it's why we commonly talk about ovarian cancer. It's why we are doing research in ovarian cancer, and it's why we're really trying hard to improve the ratios. You can see that breast cancer, although generally considered a better prognosis than ovarian cancer, actually still causes more deaths in Canada than ovarian cancer overall. So that is good to know. So risk factors for cancer. Certainly the number one risk factor for ovarian cancer and the number one risk factor for any cancer is age. Other factors include family history, never having had any children, what's called nulliparity, starting your periods early or going into menopause late, are all risk factors for getting ovarian cancer. We do know that having children and breastfeeding does reduce your risk of cancer, although it's not a risk-reducing strategy as per se. We don't tell people to go out, have multiple children and breastfeed just to decrease their risk. It's more of an association. We know people that have lots of children and have breastfed their children do have a lower rate of ovarian cancer. Using birth control pills, however, is a risk reduction strategy that we do recommend, and we know that if you have used birth control pills for 5 years over the age of 20, you decrease your risk of ovarian cancer by 50% compared to people who haven't. Other risk-reducing strategies are, of course, if you're having hysterectomy, to take out your tubes, if you're having your ovaries out, to take out your tubes, and many places are strongly encouraging removal of fallopian tubes with or without ovaries when you're considering a tubal ligation instead of a tubal ligation. And we can talk about that more, but tubal ligation by itself will actually decrease the risk of ovarian cancer by up to 50%. So all sorts of things that we know have impacts. Symptoms. Symptoms of ovarian cancer you have obviously all heard of, but they range from abdominal and pelvic discomfort, urinary frequency, digestive disorders, bloating, nausea, vomiting, pain, pressure, ascites, obviously a mass, one that you can detect, and something called a Sister Mary Joseph nodule, which is actually a nodule, a little bump in the belly button that was described by Sister Mary Joseph, who was a nun, I don't know how many years ago, as a sign of ovarian cancer. A lot of people actually have heard that ovarian cancer is a silent killer. And that has been studied in several studies. There was a paper by Goff, who's a researcher. Sorry, I don't know if there's any way to pick this up any better. So Goff is a researcher out of the U.S. What they did is they looked at signs and symptoms that patients had prior to presentation. And what they found was actually most patients had signs and symptoms for months, if not years beforehand, but they weren't recognized and they weren't investigated necessarily as quickly. So this is why Ovarian Cancer Canada and the Society of Gynae-Oncology of Canada is saying, look, if you have symptoms, go see your family doctor. Don't ignore it. Get it worked up. Get an ultrasound. Get blood work, and hopefully that will help us detect things earlier. Now, I thought I'd go through some commonly used terminology because I do know that we use these terms quite easily, but they're not necessarily something that everybody's familiar with. So when the gynae-oncologists discuss cure, what we're talking about is that the cancer will never come back ever. Now, we don't know if this happens very often. Oftentimes the studies only go to 5 or 10 years, and they use this as a marker for cure. The difference between cure and remission is remission means that there's no evidence of cancer. And you can go into remission multiple times, but we know that our best chance for cure is when you are first being treated. Relapse and recurrence are the same term. They're used interchangeably. Metastasis means any time the cancer is spread from the original organ. So if the cancer has left the ovaries or the fallopian tube, that's called a metastasis. And oftentimes people think that if they present with disease in their belly, that's not a metastasis, it's only a metastasis later on. Anytime it leaves the initial organ, it is technically called a metastasis. Staging is the surgical term we use to help us find out where the cancer is. So that's the initial surgery, the biopsies, the washings, whatever is needed to be done to find out where the cancer is. Debulking versus staging. Debulking is where you can obviously see that the cancer has started spreading outside the tubes in the ovaries, and the goal of debulking surgery is to get rid of the cancer. So sometimes staging and debulking is the same procedure. Sometimes they're very different procedures, but the goals are different. So staging, the goal is where is the cancer? We can't see it, but we want to know where it is. Whereas debulking is we can see that the cancer has spread and now we're trying to get rid of it. So, pathophysiology. So the original theory on why you got ovarian cancer was that you had lots of ovulation, so you're producing lots of eggs, and that repeat injury to the surface of the ovary caused the cancer. That's what we thought was happening, especially if you're having early periods or late menopause as risk factors. That was the theory for why it was happening. The newer theory is that actually most ovarian cancers start in the fallopian tubes and are actually just spreading onto the ovaries and growing on the surface of the ovaries. So that ovarian cancer is kind of a misnomer, and that most of these cancers actually start in the fallopian tubes. And you've probably heard about this often in media. The BC group has certainly talked about this a fair bit and are spreading the word about this. The patterns of spread for ovarian cancer, it obviously, sorry, just to ask, can you see my clicker? Like if I'm moving it around, can everybody see that? No. Okay.
It doesn't look like it, no.
No. Okay. So use my words to describe. Got it. So the patterns of spread for ovarian cancers, it starts in the fallopian tube or ovary and then spreads from there. It moves usually up the right side of the abdomen to the lining of the abdomen called the peritoneum, and then up
Dr.
onto
Altman,
the
you could
yes.
try using that green arrow if you want to drag that green arrow.
Oh, I can. Look at that. Hey, fancy. Okay. So it starts in the tube in the ovary, comes up the right side onto the lining, the peritoneum, sometimes the bowel, comes up in this direction to the diaphragm, and then the omentum, which is described here, but generally actually sits all across here. And then we find it comes down the other side and this way. And then if it spreads to the lymph nodes, it comes to the pelvic lymph nodes, which are in here, and up to the aortic lymph nodes in here. So the general thought is actually works in a in a clockwise direction. And no, it does not go counterclockwise. If you're in Australia, this is the way it moves in this direction. All right, that green arrow might be very useful. I'm going to move it over here until I need it. So the staging, like I mentioned, this is to figure out where the cancer is. We take biopsies of pieces of an omentum or the lymph nodes, and that's how we figure out if the cancer has spread. Generally, stage 1 is considered confined to the ovary or tube. Stage 2 is confined to the pelvis, so that may be the uterus or the cervix. Stage 3 is in lymph nodes or within the abdomen, and stage 4 is then outside of the abdomen or into the liver or in the fluid around the lungs or into the lungs or anywhere else. Stage 3 is our most common stage. It's the one that oftentimes goes to the lymph nodes, or you can get implants within the omentum or within the abdominal cavity. It is by far the most common stage that we see for ovarian cancer, and that's the one we talk about that a lot of ovarian cancers are presenting in late stage. Most of them are stage 3. So we have lots of questions about screening and the role of screening and should we screen. The bottom line is I wish we had screening. I wish we had good screening. We currently don't, and we have nothing that really picks up cancer early yet. CA-125 is actually very useful, but it's very useful for monitoring how people are responding to treatment. It is not very useful for detecting cancer early, and part of the reason is because there's a number of things that can cause your CA-125 to go up. And as I oftentimes describe to my patients, any inflammation in the abdomen can make CA-125 go up. So appendicitis, diverticulitis, endometriosis, liver failure, congestive heart failure, a menstrual period, pregnancy, trauma, they can all make your CA-125 go up. So sometimes a high level doesn't necessarily mean anything, which is why it's not good as a screening test. HE4 is something that is currently not approved in Canada that I know of, but we're hoping will be in the next number of years. It's called human epididymis protein 4. And again, it's not good as a screening test, but it is good for differentiating early ovarian cancers from benign cancers. So if somebody has symptoms and has a mass, if we do HE4, it really helps us figure out, is this cancer or is this something like an endometrioma? So many of you may have heard of something called the RMI, which is the Risk of Malignancy Index, which helps family doctors and gynecologists either decide, should I refer this person to a gyne-oncologist or should I look after them myself? The same thing exists for HE4, and it's called a ROMA, or Risk of Malignancy Algorithm. Unfortunately, HE4 is not available in Canada, so we can't do it. But it does exist, and hopefully we will have access to it soon. As for screening, I did actually have another slide, but I'll just talk about it. There was a study that just came out from the UK called the UKTOCS, which is the screening study for ovarian cancer out of the UK. And what they found was that there was no statistically significant difference in women who were screened or not screened. And screening consisted of CA-125 and ultrasound. They also found that there was a number of false positives. So women who screened positive that they possibly had ovarian cancer, but in the end we found that they did not. And what happened was that they had multiple interventions. So, you know, oh my goodness, this looks like ovarian cancer. You need surgery, you need interventions, you need treatments, and lo and behold, they didn't. And so at this time, based on that study and other studies, screening is not recommended because it doesn't seem to improve survival and does increase the amount of interventions for no benefit. So histotypes. There are several histotypes. This is, there you go, so generally this is an ovary. This is a follicle, and this is a follicle. This is the connective tissue between the ovary, and then this is the blood supply to the ovary. So epithelial cancers, which are the ones that occur on the outside, so this is the epithelium, which is the lining on the outside of the ovary, is the most common, making up 65 to 75% of ovarian cancers. And when we talk about ovarian cancer, this is the one we're talking about. But there are other types. This is not the only type of ovarian cancer. There are germ cell ovarian cancers, and these are cancers that start within these follicles. And these little areas in here, the germ cells, which eventually produce the eggs within the ovary. There's also sex cord stromal tumors. Those are the ones that actually start in this tissue that's between all the follicles and the blood vessels and the surface. And those sex cord stromal tumors make up 5 to 8%. And then finally, there's metastatic cancers. So generally it says 4 to 8, but I'd say 5 to 10% of ovarian cancers don't start in the ovary. They start in other areas. For example, the endometrium, breast, colon, stomach, and they just present like ovarian cancer, but they're not truly ovarian cancers. So next we go through what's the difference between grade and stage, and I know a lot of people have some confusion about this, and I have this conversation a fair bit. So stage, like I said with the staging procedure, stage means where is the cancer? Has it spread, and where has it spread to? Grade, on the other hand, is a description of how strange or abnormal the tumor or the cells look. So essentially it is, what do the cancer look like and how weird is it? The lower the grade, the more the cancer looks like normal tissue. The higher the grade, the more the cancer looks like nothing. And so when we talk about ovarian cancer, and when we refer generally to ovarian cancer, they are considered high grade or grade 3, and the stage, like I mentioned previously, is also stage 3. But the two terms are not interchangeable. Subtypes of cancers. There are low-grade ovarian cancers. There are also what are called borderline cancers. So they don't even technically fall into a low-grade category, but they are still ovarian cancers. Most of the low-grade or borderline tumors are actually caught early and have extremely good prognoses. The high-grade tumors are the ones that we commonly hear about and talk about, and those are what we generally refer to when we're talking about ovarian cancer. But even within high-grade cancers, there are different groupings. So again, serous here is the one we most commonly talk about, but there are others: endometrioid, clear cell, and mucinous, and all of these histologic types can be low-grade or high-grade. So again, when we talk about, when we refer to ovarian cancers, we're generally talking about high-grade serous epithelial cancers. So you can now imagine when people say, you know, what is my ovarian cancer? Or what is my prognosis for my ovarian cancer? There's a lot of steps that come into that decision, and some prognoses are amazing, and some are very, very bad, and some are in the middle. But I thought it was very important to clarify that when we talk about ovarian cancer and we talk about it generally, we're actually only talking about one histologic subtype and one grade of one histologic subtype. So the next thing I wanted to talk about was some associations. With BRCA mutations, we are generally talking about high-grade tumors. The majority are serous. There are other high-grade tumors that can be associated with BRCA mutations, but again, the majority are high-grade serous. You will also read about certain cancers, ovarian cancers, that are associated with endometriosis. And those types are endometrioid and clear cell. Now the association, and Maureen and I had talked about this, and I don't know if I'm going to explain it with enough clarity because it's somewhat confusing, is that these two types of cancers are associated with endometriosis, but endometriosis does not increase your risk of cancer. So just because you have endometriosis does not mean you're going to get cancer. So we know that when we look at endometrioid and clear cell cancers, a lot of them have endometriosis, but not everyone with endometriosis is going to get cancer. In fact, the rate of cancer in endometriosis is pretty much the same as the population, which is about 1.5 to 2%. So quickly talking about hereditary ovarian cancers, of our high-grade cancers, about 15 to 20% are hereditary or run in families. And by the way, this is our Walk of Hope team, consisting of several physicians and researchers and nurses within our group. Most breast and ovarian cancers, when we're talking about hereditary cancers, are associated with BRCA1 and 2, but there are other associations. For example, Lynch syndrome can be associated with ovarian cancer as well, just not as commonly as BRCA2 or BRCA1 and 2. So this is just a quick rundown of BRCA1 and 2. So the lifetime risk of getting ovarian cancer if you have BRCA1 is about 40 to 45%, and the lifetime risk with BRCA2 is about 11 to 18%. Now when you compare that to the general population of 1.5 to 2%, it's much higher, which is why we follow BRCA patients so closely. Now the one thing I want to clarify is this is not a 40-45% immediately. this is a lifetime risk. This is the risk of getting ovarian cancer in a patient that carries this gene by the time they're 70. So within any given time frame, that risk is actually much lower. When you look at Lynch syndrome or HNPCC, you can see that the risk of ovarian cancer is about 10 to 12%, but there have other cancers that are much more common within this group. HNPCC patients make about 1 to 2% of all ovarian cancers. And when you're talking about hereditary cancers being 15 to 20%, you can see that the majority are because of BRCA, not because of HNPCC or Lynch syndrome. So genetic testing for BRCA, every province has different rules. If you have questions about it, I encourage you to talk to your oncologist or your family doctor. These are the rules that I've included that are pretty much agreed upon across the country and probably across the world. So if you have Ashkenazi Jewish heritage and you have had breast cancer under the age of 50, you can be tested. If you had breast cancer under 35 years of age, you can be tested. If you are a male with breast cancer, you can be tested. This is the one that I wanted to point out to our group. If you had ovarian cancer, high-grade ovarian cancer, and depending on what province, some say non-mucinous, some say specifically serous, that by itself is a reason to get tested to detect a BRCA mutation and find out for your family. Ovarian cancer treatments. The important part here is the treatment consists of two parts, surgery and chemotherapy. One by itself is not considered good enough for the goals of cure. Now, sometimes one is recommended for various reasons. If you have multiple medical conditions that stop you from having surgery, or you can't have chemotherapy for whatever reason. So every case is individual, but generally it's considered a combination. Surgery, again, staging is to figure out the diagnosis and where is the disease or the stage, and its treatment for the disease. Debulking, as I'd mentioned earlier, is removal of all the disease, but really kind of the first step in the process. We then move on to chemotherapy, and ovarian cancer, and when I'm talking about ovarian cancer, again, I'm talking about high-grade serous, is actually very chemosensitive. And the majority, 80 to 85% of people at the end of their treatment will have no evidence of disease, and they will be in what we call remission. Unfortunately, that doesn't mean that they're cured. It means that there's no evidence of disease at that point in time. First line treatment is when you first come in, you have surgery, you have chemotherapy, and the whole point of all of that is to prevent the cancer from recurring and hopefully prevent it from recurring ever. Unfortunately, the only way we know that is in retrospect. If you live to 100 and have a heart attack and your cancer never came back, we then can say, great, we cured that person. But we never know this moving forward in time. And so a lot of patients are recurrent or have recurrence. If you have recurred in less than 6 months, it's called platinum resistant. And if you've recurred over 6 months, it's generally called platinum sensitive. And that helps us determine what to use next. I've outlined what we consider in oncology to be the perfect chemo drug. Ideally, it should work as a single agent. It should work in different ways if you have different drugs. It should have beneficial effects, and you should have as few side effects as possible. And an ideal chemo drug would only affect cancer cells. But the reality is that any chemo drug will affect any cell that's dividing. And that's how it causes side effects. It affects skin cells, hair cells, and cells within your bowel and stomach, causing the side effects that we all know about. This is a brief history of ovarian cancer drugs, which I thought was kind of interesting. Dr. Nachtigal, who's a researcher in Winnipeg, tells me that my slide is technically wrong, that nitrogen mustard and its effects on cancer was discovered during World War II, but was just used in World War I. So fair enough, correction made. But before 1980, we used melphalan and cyclophosphamide, and then you can see in the mid-80s we discovered that the platinum-based agents probably work better. So we added platinum and combined it with various other drugs as time went by. In 1996 was actually when we first started using platinum with Taxol. It was only 2000 that we started using carboplatinum and Taxol, which is actually relatively recently, although I guess that's now 16 years ago. Since then, we've used the same combination of drugs, but we've used them in different ways. For example, intraperitoneal or carboplatinum and weekly Taxol. Carboplatin, just quickly, it's a synthetic derivative of cisplatin. It does have side effects, but compared to cisplatin, it had less effects on kidney, nerves, and hearing, but had more effects on the bone marrow. But generally, we found that it was better tolerated, and the effectiveness was just as good as cisplatin, so most people moved to carboplatin as our primary chemotherapy drug. Taxol, people always say to me, well, chemo is not natural. Well, Taxol was actually derived from the bark of the Pacific yew tree, and it stopped cells from dividing. Other drugs have since been derived from the European yew tree and other yew tree derivatives. And we actually had a period of time where we were very short on Taxol because we were very short on Pacific yew trees, which is an interesting factual I learned recently. Side effects, this is the one that causes the hair loss and the numbness and tingling that we get with chemotherapy. It's the one that more likely has allergic reaction, and it can affect the bone marrow as well. So now we move into the world of targeted therapies. Targeted therapies are specifically looking at cancers and molecules within the cancer and trying to target them. So bevacizumab targets VEGF, which is a growth factor within cancers that causes blood cells to grow. That's how it works. And bevacizumab targets those and has been shown to have some effect in ovarian cancer. PARP inhibitors, well, they inhibit PARP, and I'll go through what PARP is in a minute. And then there's some of the newer agents like PLD1 inhibitors. PLD1 is a surface target on lots of cancers, but ovarian cancer included. There's some very interesting research being done on anti-tumor vaccines, including ovarian cancer vaccine targeted against CA125. And that is being studied. And other things, including viral guided therapy. Now, this is not mainstream in ovarian cancer yet, but it's very interesting research, and they are moving forward with this. Things that include changing DNA, to changing how the cancer grows, to actually using the coding of a virus to hold chemotherapy, and then using that coding to infect cancer cells and actually deliver the chemo into the cancer. Now, this isn't being done in ovarian cancer yet, but I'm sure that when the initial trials are going to be finished, ovarian cancer, I'm sure, will be included in the trials as well. So this is bevacizumab. So like I said, it targets VEGF. And what we found with bevacizumab is that there was an improvement in progression-free survival. And progression-free survival means the amount of time that you live without cancer. But overall, it didn't affect overall survival. What we did find was that in high-risk patients, overall survival was improved. And what they defined as high-risk patients was patients that could not be debulked properly or stage 4 cancers. Now, this has since been compared to dose-dense chemotherapy and found to be about equivalent. So you will find that in some centers they use bevacizumab, in some centers they use dose-dense, in some centers they can use either. There's been no evidence to use both at the same time yet, and that probably just increases toxicity at the moment. PARP inhibitors help by actually repairing. So PARP is an enzyme that helps repair DNA damage, and BRCA is actually something that helps repair DNA damage. So the idea with PARP inhibitors is you stop PARP from fixing DNA damage, and cancer cells, because they're growing so quickly, they actually accumulate DNA damage more than normal cells. And therefore, if they can't repair that damage, they will die. This is probably also the reason why PARP inhibitors tend to work better in BRCA patients, because they already have one, gap in their DNA damage repair. So the PARP inhibitor probably causes a second inhibition of DNA damage repair, and therefore those cancers are probably affected more than ones that don't have BRCA mutation. So personalized therapy, it's coming. We hopefully will get there, but I think the reality is we're not going to be there for probably at least 10, maybe 15 years. It is being done on clinical trials. I know there's trials in Vancouver and Toronto that are looking at this and sequencing tumors and trying to target therapies to those tumors. It's very interesting research, but it is not mainstream. Part of it not being mainstream is we don't have the drugs yet that have proven to improve survival that are targeted against these particular targets. Yet. They are coming and they will happen, but the research is still ongoing. And so this over here is what our current therapy is like. You know, all ovarian cancers are created equal, and we give them what we know works, and it works for some people and it doesn't work for other people. And this is what we hope one day to get to, in that we detect certain mutations in certain people, and then we can give treatments or targets specifically at that mutation. So this is where I work and live. This is our new women's hospital, which is, well, they tell me is going to be, we're going to move into at some point in 2017. I think it's probably 2018 is more realistic. And this is the bridge downtown Winnipeg, and over here is the new Museum for Human Rights, which is an amazing museum. It's I think it's the first national museum outside of Ottawa, in the Ottawa area, and it's incredible. So if anybody ever gets a chance to come out and visit Winnipeg, there are some just amazing things out here that you cannot see elsewhere. And I'm saying that from somebody who's not from Winnipeg or Manitoba. So it's about
Okay.
an hour.
That's great. No, thank you so much, Dr. Altman. You've covered a lot of territory in a short period of time, and we do have several questions that have come up during the presentation. So I will begin. The first question was related to something you covered at the beginning, and the question is the umbilical nodule common?
No, not anymore. Because we have better imaging, people present with symptoms. We can do CT scans and ultrasounds, and we can detect the cancer before it gets to that point. It was much more common when we didn't have diagnostic imaging or testing, and it was more so described as, you know, look at this nodule, that's a really bad thing. Yeah. So we don't see it very often anymore.
Okay, thank you. What about an infection like a cold? Can that increase your CA125? You mentioned a number of different things that could influence that. Can something like a cold do that as well?
That's a good question. Um, I would not usually. No, I don't think so. But there's probably situations where it can. If you have a cold that's causing you to cough a lot to the point of irritating your diaphragm, um, then yes, because diaphragmatic irritation can cause your CA125 to go up. I'm guessing you'd have to be coughing pretty hard, um, but really any irritation of the lining of the abdomen for whatever reason can cause your CA125 to go up. Yeah.
Okay. And if you do have a question, if you would please type it in that Q&A section and we'll go through them one at a time. So the next question is, when you suggest not to screen, would that include yearly ultrasounds for someone whose mother had ovarian cancer, or are you just referring to CA125?
That is a good question. No, the recommendation for ultrasounds in CA125 is the same no matter what your history. There is no evidence in any population that it makes a difference or actually benefits the patient. Having said that, there are many oncologists in this country that I know of that within BRCA patients or very strong family histories will talk to the patients about the pros and cons of doing ultrasounds in CA125s and will make individual decisions. So it is generally recommended by the Society of Gynae-Oncology of Canada not to screen in any situation. The caveat is that it is always a discussion with your oncologist and your family doctor in an individual situation.
Okay.
I hope that made sense.
All right. Next question. Seems like my screen is, there we go. Okay. My screen is acting up here a little bit. Okay, so another question is, do we have a good knowledge of the somatic genes in ovarian cancer at this stage, like in breast, lung cancer, or melanoma? If not, why is this taking so long?
So I guess the answer is yes and no. We have certainly done lots of testing on the somatic mutations in ovarian cancer, and we've detected lots of them. We like to think that we have an idea of the main players, but the difference, I think, between breast and lung and melanoma or even others is that ovarian cancer genes, there's lots of them that can be mutated. And so every cancer is actually remarkably different. And so trying to find common genes is actually where we run into more problems. In that it's not a matter of can we find a gene in this cancer, it's a matter of can we find a gene in this cancer that's common across multiple cancers that then we can use as a target. So if you had one cancer in one patient with one gene mutation, that same mutation may not exist in other people. So the key is to find genes that are not just kind of one-off mutations, because we really don't know what that means. It's more so finding mutations that are consistent across cancers. And we have found them. P53, BRAF, KRAS, BRCA, and there's treatments that are being developed against all sorts of different mutations. That's where we're still kind of waiting for the research to catch up.
Okay, next question. What is the typical prognosis for someone with clear cell carcinoma stage 1C high grade that is associated with endometriosis?
I guess the overall answer is generally good. Um, Most clear cells present with early stage, so stage 1 as you described, and most stage 1 cancers have very good prognosis after surgery and chemotherapy and treatment. Obviously not all, um, but yeah, the prognosis is generally good. Yeah.
Okay, I'm just having a bit of trouble here with our Q&A, but another question, we're working on it. Is surgery an option in a case of recurrence? If so, when is it an option and when can't it be done?
Is it an option? Yes, sometimes. um, so it's a complicated answer. The longer people go from their initial treatment to when their cancer has recurred, the better. Um, if the cancer has come back in a limited number, so maybe one or two spots, that again kind of pushes you to say, okay, we can cut that out, so we can try to cut that out. Um, when it can't be done is when the cancers come back in multiple different areas, because then you can't cut it all out. You're putting someone through a very big and morbid surgery for no benefit. Or if the cancers come back really, really quickly, because then the cancers kind of said, look, I'm more aggressive and I'm growing awfully fast, so even if you do cut it out, I'm going to come back again. So there's multiple things to think about when you're thinking about surgery for recurrent cancer. It's called secondary debulking. It absolutely does exist. It is absolutely done, but the situation is very individualized.
Okay, people have started to type their questions in the chat box, which is great. Um, will someone platinum sensitive stay that way in recurrence?
So platinum sensitive is defined when someone recurs. So when someone recurs, if it's been over 6 months, they're defined as platinum sensitive. I'm guessing the question is when they recur again, will they be platinum sensitive? Not always. And most cancers, if they're platinum sensitive the first time, may not be the second time, may not be the third time. Eventually, they will become resistant to platinum, and the oncologists will choose to move on to a different drug or combination of drugs.
Okay, Ronit had typed a question about maintenance drugs, and unfortunately we can't see the whole question. So if you'd like to retype it in the chat box, then we will be able to ask it. So the next question is, could you discuss the prognosis for high-grade serous stage 4 cancer? And the second part of that is, why has research taken so long to focus on ovarian cancer versus breast cancer?
Sure, that's a great question. Um, stage 4 is not good. That is the bottom line. Are there people that are cured in stage 4? Yes. Are there many? No. The general number is about 10 to 15%. But unfortunately, we don't know who will be cured and who won't be cured. I know I have, oh, sorry, my screen just died. Hold on a second. I know I've had a patient over my years that was initially stage 4. And when I saw her, she was 15 years out from her initial treatment and still disease-free, which we generally wouldn't predict, but it absolutely can happen. So yeah, that's about the answer for prognosis. Why has it taken so long for research to focus on ovarian cancer versus breast cancer? Well, that's unfortunately an easy answer. Money. Breast cancer is much more common. It affects 12% of the population. If you're affecting, 1 in 8 women, you're going to have a lot more of the population that is supporting breast cancer, that is providing money for research, that is funding trials. They are a bigger, louder group. And that may not be the PC answer, but that is true. The rarer the cancer is, the less research that's done on it and the less funding that it has. So if you look at the big research groups, breast, prostate, lung, they are the most common cancers out there. So.
Okay. Well, I think that is the end of our questions. Oh, there's one more being typed. While we're waiting for that last question, I'll just let you know that we have 3 webinars coming up in the month of November. There will be 2 in French, so Ovarian Cancer 101 will be offered in French on November the 8th. And then we begin our series on recurrence, and this coincides with our launch this year of our new resource guide called Still By Your Side, and it is for women who are dealing with recurrence. And this is a companion guide to our original guide called By Your Side for women who have been recently diagnosed with the disease. So we're running a short series on recurrence, and the first one will be fear of recurrence, which is a very common thing for women who've been diagnosed with ovarian cancer. It will be offered in French on November the 23rd and in English on November the 24th. And then the 2 follow-up sessions on recurrence will be offered in the new year. So you can watch our website for those upcoming webinars. So here's the last question. Does having a father with prostate cancer raise your risk of ovarian cancer?
No, probably not. So the answer to that, I guess, is prostate cancer certainly is increased in BRCA carriers. Having said that, essentially any man that lives long enough will get prostate cancer. Now, my prostate oncology is a little behind because I don't do prostate oncology, but I think the general rule is that 70% of men by 70 and 80% of men by 80 will have prostate cancer or a pre-prostate cancer type of lesion. So it's really common. So that by itself does not increase your risk of ovarian cancer. Now, I guess if your father had prostate cancer at a ridiculously young age, maybe, but I've certainly never read anything about that by itself.
Okay. Well, if there's one last question coming, we are right at the end of our time together. I think we will need to close off. There are several comments coming in now thanking you, Dr. Altman, for your presentation. Great answers, comprehensive presentation, and you really have covered a lot of material and made it very easy to understand. And so we thank you so much for what you have presented tonight and for the time it's taken you to do that. And I want to thank everybody who has participated in the webinar as well. And you will be sent a follow-up email with a short survey. So please take just a few minutes to fill that out. It gives us some good feedback and about other topics that you might be interested in hearing about. And so this last comment is thank you so much, Dr. Altman, for taking the time. Thank all of you for participating. And please watch for our upcoming webinars in November. So that is the end of our presentation tonight, and we hope you have a good evening.